Welcome to the Operatory, the podcast about burying the dinosaurs in dentistry, moving past outdated procedures and technology to find a better way. I'm having trouble getting through the intro today, David Pryor and beatboxing Dr. Brad Eli. How are you guys doing today?
Good, Brian. How are you?
Very good.
That was the most fun beginning I think we've done. And Dave's usually pretty goofy in here, but having two goofy people.
Well, yeah, doubling down on it really threw you off your game.
It did.
I'm excited.
Yes. And I'm excited because this topic today, it's the wrapping up the four-parter, number 4 of 4, with Dr. Brad Eli, discussing facial pain, going from, I can't even remember what the first week was, but it was about kind of just, the fact that there are facial pain as a specialist that we should be referring patients to, those patients that we don't know why they're not getting better. Moving into just kind of how dentists can cause facial pain and TMD disorders doing routine dental care, and then also what to do about it. And today we're going to take a step back, look at the forest through the trees, and kind of what the state of treating facial pain TMD disorders are and where we think it should go in the future. And so from my perspective as a dentist, I look at kind of what most general dentists do now. You kind of have, I see you grind your teeth or you have some problems. And if you really want to do something about it, let me know. Or I'll give you a treatment plan for a bruxism appliance that's probably $600-$800, right? And the patients freak out. And then they might go on Amazon, buy something for $20 that sucks. Or they go, I made you a bruxism appliance. You're not getting better. I have no idea what's going on. And hopefully they find somebody that they can refer to. And lots of times, as we've learned from you, that person that they refer to may have one formula that they kind of give to everybody. And so that's, have I accurately described the state of dentistry and facial pain today? Or is there something that I've daved?
Oh my God.
That was sweet.
Yes.
No, I think
The compassionate dentist.
Oh, sorry.
Brian
yeah. Compassionate Dentistry by Brian Laskin.
I've got to explain to the audience, because if you haven't listened before, Dave's been a friend of mine for 25 years, and that's what we males do, right?
Yes.
Bonding moment.
We make fun of those we love.
Yeah.
He's bonding his door locked for a while.
Well, so what TMJ disorders has been the redheaded stepchild of dentistry for quite some time.
Okay.
So before I did my postgraduate training, did a lot of weekend coursework in that field, and those weekend course educators do a great job of teaching you how to provide a service.
Mm-hmm.
So when I look back on it, I think that I learned, I went to 5 extensive weekend training programs given by different people. And when I look back on that training, I realized that one of them taught me how to make an apple pie, and every single patient, no matter what they showed up with, ultimately got an apple pie.
Mm-hmm.
And then the next guy said, apple pies suck, it's pumpkin pies.
Mm.
And so then in my head, I was thinking, well, I guess there's some people who could like apple pie and some people who could like pumpkin pie. So I went to a third one, and it was apple pies suck, pumpkin pie sucks, it's pecan pie.
Gotcha.
So after the 5th one, I realized that I was learning religion, which makes perfect sense as long as you don't learn more than one religion.
Gotcha.
Okay.
Yeah, which is what, and they fight, right? In
Oh
dentistry.
my God.
Yeah.
Oh my God. It's unbelievable.
Yep.
So the thing is that as long as you need that apple pie, you're good.
Mm-hmm.
But many times you don't need the whole pie, and you really don't need a pie at all. Because it ends up that you're a diabetic, and you would do a lot better with a sugar-free piece of cake.
Gotcha.
So postgraduate training puts you into a thinking mode more than a doing mode. So, I had the pleasure of boring you to death with some things that I've developed to try to explain not only to patients but to dentistry, what this is all about. And the reality is that general dentists are trained to take care of one standard deviation from the norm of the population. 95% of the population is successfully treated by general dentistry. Very well, very adequately. Then 2 standard deviations from the norm, we pick up the specialties of dentistry that are known, the specialties of medicine that are known. So you have multiple pies, but this person needs a cake. So you send them to the cake maker because you're the pie maker. So my training was, well, what if a cake and a pie don't work? Then what do you do? So that's 3 standard deviations, which represents 1% of the population. And this 1% of the population was driving both medicine and dentistry crazy, and they were just going back and forth between the specialties. So that's why this field was created. So then the next step that we had to come to is, okay, well, how do you separate out for a person or a patient what takes a thumbtack to fix versus a headless nail versus a drywall screw versus a 16-penny nail? So unless you know all of those resources exist and know how to use each one of those resources, then you're stuck with only the resource you have. So dentistry historically said, I only have a thumbtack, therefore let me use my thumbtack and fail to prove that you need more than a thumbtack. The problem is the cost of the thumbtack was so great that A, the patients couldn't afford it, and B, the general dentist got a little pissed, if that's a word that we can use on a podcast.
Absolutely.
But, they got a little pissed because they were taking care of every part of the patient, and they got, $2,000 last year for taking care of everything. And the guy that saw them twice and did something that the general dentist looked at and said, I could have done that, got paid $10,000 for it.
Well, and so because I like your analogies a lot. You lost me on the screws and nails because I don't even hang pictures at my house. But
Scotch tape.
Yeah, there you go. Yeah,
It's all 3M
good
strips,
3M product
to be
for
honest.
Minnesota, exactly. But what we're really talking about is an occlusal guard, right? That if you come to my office and you grind your teeth and I send you, and hey, that guy got paid $10,000 to make you an occlusal guard, I can send it and have that made, right? I might as well do that myself and charge the patient $800 instead of $5,000. And then if it doesn't work, well, now I'll refer them over.
Right.
And so when you're talking about the stratification of facial pain and TMJ disorders, you're talking about sort of a relatively inexpensive way to fail. Is that right? I mean, or succeed. Yes.
So this is a very common theme that patients run into all the time. The age of I'm going to start with a dentist and I'm going to stay with the same dentist for 30 years is no longer really the common because of insurance. You're on my panel or you're not on my panel. So people are going from office to office a lot more. And so if I'm 45 years old and I go to a new office for the first time, get my teeth cleaned, and
Dave?
I'm told,
Yes.
you
What?
grind your teeth, Dave.
Yeah.
And you're thinking, hold it. The last guy that I saw for, 20 years didn't tell me that. So you're telling me that I'm doing something that I don't think I'm doing.
How could that be?
That happens all the time.
All the time.
All the time.
That is such a common thing. You wouldn't believe it.
Because I would, so I read a statistic, and you tell me if I'm wrong, that about 30% of the population bruxes in some fashion, the adult population. Maybe I'm wrong. I don't know if that's right.
It's probably a little higher than that, but
Okay. Well, higher.
convincing a person that they grind their teeth is really not the point.
Yeah.
The point is...
But I don't think that 1/3 of the people are being told by their dentist that they probably brux.
So if you grind your teeth in this era of materials that keep getting harder and harder and harder, then I, as an expert in the 1%ers, will tell you that I would absolutely say that 100% of the population you have in your office should be wearing some sort of protective device over their teeth, because once the material enamel is lost, it's gone. So now you've lost a irreversible thing. You're not really doing your primary role/goal, which is keeping the person healthy. So the quick splint product, again, was this intermediary. And so the hygiene department says, we are concerned that you may grind your teeth. There's information in your reception area that talks about tooth grinding and allows a patient to interact with questions that kind of promote this conversation. And then for the people who say, well, I don't know if I do or not, for a very, very minimal cost, you can wear something. You wear it for a month. You come back, and grinders will grind a hole in that thing, in which case there's no longer a conversation as to whether or not you grind your teeth. The conversation is, what are you going to do about it? So that's what we've actually seen. And so the second part of that story is using temporary devices or transitional devices to cost effectively stratify out the people who, A, only need protective devices. So I refer to them all, splints, night guards, mouthpieces, you name it, as being appropriate for the general dentist to provide. If a person has a pain complaint, then you're talking about an orthopedic device, which will often to a patient look the same as the bruxing device that the dentist has made for them. So that's a conversation that I have to have with patients all the time. Why am I going to get another one? I already got one from my other guy, right? So the line that I draw, and hopefully I draw for your listeners, is if a person has a symptom, don't just try to use something. Like, that's a person that you're going to own that symptom if you interact with that symptom. So if you are interacting with a person that has no symptoms, you're just protecting their teeth, then you're going to make them what I call a fitted night guard. And I liken them in my analogy to going to the Nike store and getting fitted for a pair of Nikes. But what we make in our office is Kobe Bryant's Nikes and LeBron James Nikes, which I guarantee you will not find in a Nike store.
Even though it has a picture of them on the box.
Looks like the box is the same. Yeah. The size is the same.
I don't think the size is the same.
They just don't blow out quite as easily.
Yeah. Well, that's great. And thank you very much. It's very enlightening to me, and I'm sure to the audience, because I think, we live in Minnesota is one of the states that has a facial pain program.
Correct.
And there's only 12. And so there's a wide variance across the country of training in TMJ facial pain. And And I think that it'll be enlightening to a lot of dentists, patients, dental team members. So that's why I wanted to take the time and do a 4-part series on this, because I think it's a very crucial issue, and the information that you're providing is not it's just not out there readily for people available. So I thank you very much for coming in, Dr. Eli. And for Dave Pryor, thank you, sir, for being here, providing the patient perspective throughout the entire 4-part series with Dr. Eli.
You got it.
Well, thank you very much, guys. Appreciate it.
Thanks again.
Thanks, Brian.
For more information about TMD facial pain and how to treat these patients with products like the Quick Splint, go to quicksplint.com. I also want to remind you to rate and review us wherever you're listening to this podcast. And if you have suggestions or comments, please visit theoperatory.com and drop us a line. Again, I'm Dr. Brian Laskin, host of The Operatory. Thanks for listening. I look forward to speaking with you next week.